First off, welcome to Parkinson's Pulse, a virtual event designed exclusively for the WeHealth Parkinson's disease community. We're very glad that you could all join us today. My name is Murad Saidi. We've connected with some of you. I'm the co-founder here at WeHealth. Our mission at WeHealth is really to help connect patients like yourselves to resources, support, and clinical research opportunities. And we're incredibly excited to have you all here for our first live webinar. A lot of effort has been put behind designing this event to ensure that it aligns with your individual interests. Thank you to each and every one of you who took the time to share your topics of interest and questions in preparation for this event. I'd really also like to thank Joanne Tsai, our head of patient engagement, Will Rosh, our founder, and Dr. Daniel Kantor, of course, our expert neurologist, for their efforts in making this event possible. Today, Dr. Kantor will be diving into the main topics you are all most interested in, which include understanding Parkinson's disease, managing Parkinson's symptoms, treatment options, and living with Parkinson's, among others. The final 15 to 20 minutes will be set aside for a live Q&A for anything that comes up during the session. So please make sure to write your questions down or feel free to add them to the chat as they come up so we can address them at the end. Without further ado, I will now pass it off to Dr. Kantor to introduce himself, and we'll get things started. Dr. Kantor, take it away.
Thank you. Hello, everyone. My name is Dr. Daniel Kantor. I am the President Emeritus of the Florida Society of Neurology. I'm an adjunct professor in the Department of Neuroimmune Medicine at Nova Southeastern, as well as affiliate at Florida Atlantic University. The topic we're going to talk about today is about Parkinson's. And we're going to talk about how we as physicians, as neurologists, see it, and how maybe you can work with your neurologist to better understand your particular condition. So, it was 1700s, and there was no diagnosis or no disease called Parkinson's disease. And then in 1817, Dr. James Parkinson started describing people with what he called paralysis agitans. And he actually did really what's urban medicine. He went around and he saw people who were on the street. He saw people in their real conditions, not bringing them to the clinic. He saw people out and about, and he saw people who had shuffling gait. He saw people who had resting tremor. And by his descriptions, back in 1817, we now have the condition that we call Parkinson disease. You'll notice sometimes I say Parkinson disease, and other times you'll hear people say Parkinson's disease. From a technical point of view, it's Parkinson's disease because it's named after him and it's not his disease. So it's not Parkinson's disease, but all the time it's called that as well. So what makes Parkinson or Parkinson's disease different than other conditions that a neurologist might take care of or that people might have? Well, neurologists, as all of you probably know, are specialists who specialize in the brain, spinal cord, and optic nerves of people. And there are several what we call neurodegenerative conditions. I don't love the term. It's a little bit outdated, but it's still commonly used. And the idea is that our neurons, our nerves, our nerve cells in our body are supposed to work optimally. When they don't work optimally, then we say they can degenerate, they can break apart. And what we think happens is there's a very common neurodegenerative disorder named Alzheimer's disease. And then the second most common is called Parkinson's disease. In Parkinson's, we have an effect on more specifically the dopamine producing cells, but also other cells that are in the human brain. We need these cells to help us think. We need these cells to help us move. We need these cells to help us do all our daily functions. And when you start to have problems where the cells break down, either because there's not enough energy, the energy metabolism is incorrect, there's too many oxidative stress going on, and not enough antioxidants. For all these various reasons, you could see a breakdown of the neurons. When a person starts to have about 80% of their neurons in the areas that are involved with Parkinson's disease, when they start to have 80% of them being affected, then what you have is you start to have clinical effects of Parkinson's disease. But even before you have a clinical presentation, you're actually going to have symptoms that are years to decades earlier. Some of the most common symptoms that can be earlier are things like anosmia or hyposmia. So either lack of sense of smell or reduced sense of smell. When people have that with Parkinson, you ask them questions and they say, looking back, 2 decades before I was diagnosed, I actually had that problem as well. I also may have had problems with sleeping, with REM sleep behavior disorder. We know that when we sleep, we have REM sleep, rapid eye movement sleep, and non-REM, non-rapid eye movement sleep. And one of the tricks of how the human body was either evolved or created was that when you're dreaming, you're not acting out the dreams. And so when you're having that REM sleep, what's going on is your body is otherwise paralyzed, because otherwise every dream that we have, we would act out in our sleep. When somebody has a problem with their REM sleep, then we actually call it REM sleep behavior disorder. And that can also be seen years, decades before a diagnosis of Parkinson's disease. Constipation. Now, constipation is a very general term. It can happen with almost anything. You don't drink enough. None of us drink enough water all the time. And there can be medications that can do it. But we also see with people with Parkinson's disease, we can actually see involvement of the gut, involvement of constipation years to decades before the actual diagnosis. Now, if you have Parkinson's disease and you don't have these things, it doesn't mean you don't have Parkinson. What it means is that these weren't the types of symptoms that you had earlier on. So how does someone get diagnosed? Well, what happens is usually a person or their loved ones is going to start noticing something. What they oftentimes will notice is a tremor, and we call that tremor usually a resting tremor. What we mean by that is it's not so much a tremor when you're trying to reach for something. It's a tremor when you're just there doing nothing. And you probably will see it more on one side than the other. And it won't necessarily have to be whether it's your dominant side or your non-dominant side. If you're right-handed, it won't necessarily be the right side, or if you're left-handed, it won't necessarily be the left side or the right side. People just seem to have beginnings of Parkinson's a little bit different on both sides. And oftentimes when you start to see symptoms on one side, then what can happen is Parkinson can unfortunately progress and can go and travel to the other side as well. I mentioned tremor. Tremor is one of the cardinal signs of Parkinson's disease. It's one of those things that when you think about Parkinson's disease, you think about. But not everyone with Parkinson's disease has so much of tremor or has tremor as such a big part of their symptoms. Other things that can be there are bradykinesia. So brady means slower and kinesia means movement. So slowness of movement. You can have a person with Parkinson who will not be able to move as fast as somebody who doesn't have Parkinson's. Another cardinal sign that we have is one called rigidity, where your muscles actually feel tighter, and it's a little different than spasticity. And some of you may have heard of spasticity, where a limb might be spastic, especially somebody with cerebral palsy or somebody with other conditions with a stroke might have spasticity. Rigidity is that muscle being hard to move. And we call that specifically in Parkinson cogwheel rigidity. Cogwheel rigidity because as you're moving that person's arm or leg, you start to feel almost like a cog wheeling. And that's because you have tremor superimposed on the rigidity. People with Parkinson often will also have postural instability, meaning that when you stand up, you have a tendency to fall backwards. You have a tendency to not be stable. And many of you who have gone in to see a movement disorder specialist know that they do the Simon Says of examinations. We call this the Unified Parkinson Disease Rating Scale, or UPDRS. And it's looking mostly at the motor effects of Parkinson disease. And the doctor will grade how your movement is compared to how it should be. So there should be no tremor. And if you have a tremor, that gives you some points. If you have more tremor, it gives you more points. And one of the tests that are done in the UPDRS is actually when you're standing up, your doctor will come from behind and they'll tug on your shoulders just to kind of pull you back so you take one step backwards. Somebody with Parkinson's disease oftentimes won't be able to stop at just one step. They'll just keep on going backwards a little bit. And what this tells us is that not only is it your actual movement, it's also how your body sees itself in space during the day. And in order for that to work properly, our nerves have to be working great. So what do we do to make our nerves work as best they can? Well, somebody with Parkinson's disease may have a family history, although usually not. It's not as genetic as some other conditions in neurology are, but there may be a genetic component for a minority of people. There are probably lots of associated genes that we just don't know about yet. And I predict that in the next 5-10 years, we'll learn more about different kinds of genes that are associated with Parkinson's disease that you're a little bit more likely to have. Doesn't mean you'll have Parkinson, doesn't cause Parkinson, but you're a little bit more likely to have if you have Parkinson or not. Another condition that can lead to somebody being diagnosed with Parkinson's disease is going to be exposures. And it's been well established now that certain environmental exposures, such as agricultural work, working with the pesticides, herbicides, having exposure to these can actually, rural living, can actually place a person at greater risk of having Parkinson's disease. And we actually looked at this a while back, about 20 years ago. We took a specific herbicide and we put it into a Petri dish, and it made the cells degenerate and act more like those of Parkinson's disease. And so while not every exposure we understand exactly how it works, we understand that mostly these exposures put you at a greater risk because they make your body more likely to degenerate. But why does it happen? Why is the degeneration happening? And that is the unanswered question. We don't know why one person will live their life, they'll be 90, 100 years old, they'll never have a problem with movement, and another person, even before the age of 50, might have a problem. Or a person might have a problem in their 60s. Why is it that some people's nerves or neurons degenerate and other people's don't? And that's what we don't understand. So one of the things we're trying to figure out is what happens to these neurons? Why do they degenerate? And some of the aspects that we look at, for example, are something called a problem with autophagy. Autophagy is the normal way that cells live and then die and then are almost eaten up by the person's own body. And a person with Parkinson's disease may have problems with the autophagy. They may have problems with energy metabolism. They may have problems with how their cells take energy and turn it from glucose, from sugar, to actual energy that we're able to use inside the human brain. There's some interest in a particular type of protein called alpha-synuclein. And what happens is, in a person with Parkinson's disease, if you look under the microscope, you will see, oftentimes, something called Lewy bodies, which is basically clumps of these proteins that aren't working right, but that are clumped all together in a person with Parkinson's disease. And there's some interest now in trying to figure out medications to actually fight that and to reduce the amount of the alpha-synuclein. Personally, I'm not sure that this is the right way of us moving forward with Parkinson's disease. Many of you may have heard of some of the controversy surrounding recent FDA approvals of medications for Alzheimer's disease. And there, instead of alpha-synuclein, there's another protein aggregate called amyloid. And it seems like fixing the amyloid doesn't really have that much of an effect on the person's thinking, on their dementia, but it can reduce it a little bit, and it can reduce on specialized imaging, it can reduce the amount of amyloid that's there. But it doesn't mean it's making the person better. And one way of understanding this is that when you have alpha-synuclein in the case of Parkinson or amyloid in the case of Alzheimer's disease, when it's clumped together, all that is that's like looking at the garbage bags outside of a house party. It's not telling you anything about what's happening inside the brain. It's not telling you anything about what's going on inside that person. It's telling you that there's waste that needs to be cleared out. And so even if you reduce that waste, you haven't done anything to affect what's going on inside the brain itself. And that leads us to what is the greatest unmet need in Parkinson's disease. In some conditions in neurology, we started to have medications that not only help the individual symptoms, and those symptoms might be motor symptoms like I've talked about, but they also may be non-motor symptoms. They may be things like depression and anxiety. They may be things like problems with sleep. They may be problems like problems with your blood pressure, where your blood pressure will be erratic and will actually reduce when you stand up and can even make you dizzy. You may have problems with urination. All of those are the non-motor symptoms of Parkinson's disease and can actually be seen in Parkinson's disease. We don't fully understand why. One of the reasons we don't understand fully why is that we think dopamine, it's one of the neurotransmitter that's the most important in Parkinson's disease. We think of dopamine producing cells as being affected. But we know that other cells must be affected because it's not just dopamine that's a problem in Parkinson's disease. And so we have to try to figure out, how do we actually change the course of someone's disease? Not just to help them move better, not just reduce the tremor, not just to give a person more functional time, but how can we actually go and change the course, change the trajectory of their diagnosis? We call that disease modification. And unfortunately, in the field of Parkinson, we don't have a disease-modifying agent. The most common medications used are medicines that have to do with dopamine. So one of them together, carbidopa, levodopa, oftentimes called Sinemet, and all its variations, is the most commonly used type of treatment for Parkinson's disease. But whether you start the Sinemet now or you start it later, it's not going to change the trajectory of that neurodegeneration. It's not going to change the trajectory of the problems that you have. It just will give a person more time that they can be doing more of the things they love, which is important also. But that's helping the symptom and not helping to change the course of the diagnosis. So how can we actually affect the course of the disease? Well, one way is to try to get the cells that are already there working better. Another way is to try to get cells that aren't being recruited and aren't working, neurons, try to get them to take part and to help out the other cells that are already dying. We can either protect cells from being damaged, or once they're damaged, try to bring them back up to a healthy function. That's why it's so exciting. I actually, aside from being a neurologist, I work for an institute called Gateway Institute for Brain Research. And it's a very simple institute mission. Our mission is to cure Parkinson's disease, not treat the symptoms, but eventually to find a cure. And so with that single focus, what we try to do is we do mathematical modeling of how neurons work. We actually have computer programs. Then we have labs with a Petri dish, and you're actually affecting cells. Then we have animals. Unfortunately, animal experimentation still does happen in medicine. And then we have clinical trials. And we're trying to move more away from the idea of animal studies, partially because there's no great animal model of Parkinson. There's some models we use that the rodents look like Parkinson, but it's never exactly the same. It's never caused by exactly the same thing that a person's Parkinson's disease is. And one of the things we believe is that it's probably going to be individual for different people. And we're really going to have to personalize or deliver precision medicine. So for one person, it may be a problem more of cell death, and another person may be more of a problem of the energy metabolism. And we're trying to test people's blood to be able to tell us what kind of problems do you have that are causing your specific Parkinson's disease. But aside from that, we also want to look at different symptoms. And one of the symptoms we're looking at right now is a symptom of cognition. Cognition is our thinking. So people with Parkinson's disease may sometimes have problems with cognition, with thinking. And it could mean that it's hard to do multiple things at once, to multitask. It could be it's harder to keep things on top of mind. You may be slower at doing calculations compared to how you used to be. And we have questions about whether we can deliver medications not necessarily to cure the Parkinson, but can we actually also just help some of these symptoms that are harder to treat? In terms of disease modification, we can think about several ways that can happen. One way is not using medicines. So what can you do about your diet that can change the course of your disease? What can you do to make your Parkinson's best it can be? You didn't ask for the diagnosis, but once you have the diagnosis, then what happens is you have to think, how can you fit it into your life? How can you continue to live the fulfilling life that you were always living, and just integrate that into your condition? Well, there's no one particular diet that's called the Parkinson diet. Overall, you'll hear recommendations that will be things like, eat whole foods, not reduce processed foods. These are recommendations that, frankly, all of us should be doing, whether you have Parkinson's disease or not. We probably should go back more to more vegetables and more fruit. We probably should eat less and less gluten, so less and less wheat products. And we probably should have less red meats, more fish products than we do in the American diet. Specifically in Parkinson's disease, as well as some other neurological disorders, they've looked a little bit at something called the ketogenic diet. And the ketogenic diet, instead of using glucose or sugar as your main source of energy in carbohydrates, it's using something called ketone bodies. And the human brain is the only part of the body that can use ketones for energy. Everywhere else, you need actual sugar, you need glucose. But the human brain can continue functioning just with ketones. And we know that's true. For example, if you think about Gandhi, he was able to stop eating and fast. His body continued to wither away, but his mind was still working. And that's because his mind didn't need glucose, it didn't need sugar. It was using something called ketone bodies. And there's some data to suggest that ketone bodies are actually going to be beneficial in a person with Parkinson's disease. So some people with Parkinson's disease, if they want to try a diet, one of the diets that they will try is either a ketogenic diet. Atkins diet is a little bit similar to the ketogenic diet. A pure ketogenic diet is very, very difficult to do, and you need really the whole family to be involved. But to try to reduce as much the carbohydrates and you're increasing the other forms where the energy can come from. So you're increasing the fats actually, and you're increasing the proteins as well. So that's if we want to use diet. Now, what if we want to use complementary and alternative medicine? People used to think that allopathic medicine, that's like MDs, medical doctors, were called allopathic medicine. So what we think of traditionally in the United States when we think of a doctor, people used to think, well, it's not very integrative, it's not very holistic. I actually think that in some ways, allopathic medicine is one of the most holistic of types of medicine that we do, more than, say, homeopathic or naturopathic, because we're not stuck to a dogma. For example, in homeopathy, the idea is you give a little bit of something, and instead of making something worse, it makes it better. So if you have a problem with your lungs, you take arsenicum, which is like arsenic, at very small doses, and that little bit will help the lungs work better. You would think with homeopathy that they would really believe in vaccines, but unfortunately, they say, well, we shouldn't give something, even a little bit of something, if you don't already have the condition. And so you don't want to preempt it with a vaccination. Now, in allopathic medicine, I don't care so much about whether it fits into the dogma of how I believe or what I think I know about Parkinson's disease. What I care really about is whether it makes you feel better or not. And so that's why things like acupuncture in general has entered regular medicine. You remember 20 years ago, your medical doctor probably never recommended acupuncture. Now, many physicians will recommend it. Do we think it works because of the energy cheese? I don't know. I don't think so, but I'm not sure. But I don't know how it works. But I do know that for certain conditions, it can help. But remember that when we're talking about complementary and alternative medications, we're talking about complementary. What can we do to complement what we already have? So what do we already have? Well, we have non-surgical ways of treating Parkinson's disease, and then we actually have surgical ways of treating it as well. So when you think about the non-surgical ways, most common by far is going to be something that affects dopamine in some way. And if any of you have seen the movie Awakenings, with the idea of the people who were frozen, they thought after the Spanish flu, but they were frozen. And then when movement started happening around them, they were able to suddenly catch the ball. They were able to suddenly move. That's similar to what happens to people in Parkinson's disease, where you may get stuck. You may what we call freeze while you're walking. It's not that you're cold, it's just that you're not able to continue movement. And then if there's a checkerboard on the floor or something else that cues your eyes that there's movement, it will help you be able to move. And that's why people in that movie, for example, were able to catch the tennis balls that were thrown at them. And so when we're looking at that has a lot to do with how dopamine interacts in the body, and the way they treated them in Awakenings, and the way, frankly, most people treat in the United States is through that same type of medication, carbidopa, levodopa. The levodopa we think has the actual effect. It puts the dopamine in the brain, but the problem is it's going to be broken down. Dopamine, if you just give dopamine, it gets broken down in your stomach. And so carbidopa keeps it around longer, keeps it around so that it can travel to the central nervous system, to the brain, and get converted into dopamine and help you by having more dopamine. Another way of treating is you use something called a dopamine agonist. So these are medicines that aren't dopamine, but work similarly to dopamine. And you may have heard medicines like Requip or Mirapex, Pramipexole, where what happens is it's not carbidopa, levodopa, so it's not the same as Sinemet, but it is acting like more dopamine. It's acting like the same type of medication that dopamine will do. We have other medicines that are, for example, monoamine oxidase inhibitors. Monoamine oxidase is going to be one of the enzymes. An enzyme is just a fancy word for one thing that breaks other things down. And it's going to break down dopamine. And if you inhibit it, then the less dopamine gets broken down. So there's more dopamine. And as you can tell, I've talked about dopamine, dopamine, and dopamine. But Parkinson's disease is more than just that. It's not just a depletion in selective areas of dopamine. It looks like it affects other types of cells as well. And so why does that happen to someone? Well, one thought is that maybe there's something autoimmune going on in the body. Now, an autoimmune disorder just means auto means to self, and immune means your immune system. Your immune system is basically the body's defense forces against outside invaders, normally against viruses, fungi, bacteria, but sometimes it can be directed against you personally. When that gets directed against the pancreas, we call it type 1 diabetes. When it gets in the skin, against the skin, we call that psoriasis. When it gets against the joints, we call it rheumatoid arthritis. And if there can be a selective part to the dopamine being attacked, it's possible that maybe Parkinson's disease has a component of autoimmunity. That's still an unanswered question. It's one of the questions we're actually trying to answer at Gateway, to try to see how much is the immune system not just a bystander there, but actually causing part of the disease. Not just that you have a reaction to what's going on in your body, but also that the autoimmunity, the body attacking itself, is actually part of the condition itself. Now, there are variations on these medicines. There's, for example, now there's medicines where you deliver dopamine, you deliver carbidopa, levodopa directly into the gut. And so you have a pump that you get implanted that's able to do that. You can have longer acting carbidopa, levodopa. These are all just variations really on the same basic idea. And it's interesting, when I went to one of the American Parkinson's disease meeting, you can feel it in the room. You walk through the halls and it's palpable that the field of Parkinson's disease is ready for a disease-modifying therapy. So one other way we think that maybe we can disease modify is, aside from looking at each individual person and seeing what is the dysfunction and how do we fix that dysfunction in that person, which is obviously very time intensive and very different for everyone, we can maybe give something called stem cells. And stem cells have been in the news a lot, and sometimes there's some misunderstandings about them. Stem cells, firstly, can be either allogeneic or autologous, so either from other people or autologous from yourself. It can either be hematopoietic, so having to do with the blood system, so cells that become white blood cells, for example, or it can be something called mesenchymal, and that's more like cells that can become other things, like, for example, neurons. And we think in Parkinson's disease that perhaps we're going to be able to develop a type of stem cell that's mesenchymal stem cell, and that's going to help the body. Not necessarily, we used to think it was replacing the dead neurons and making new neurons. Now it looks like it's more about creating an environment where your neurons, your cells can actually flourish and they can grow on their own. So you're not actually using a stem cell to replace something, you're using a stem cell to make it possible and give signals for one cell to help another cell and for the neurons to be working better together. Because that's the problem in Parkinson's disease. The neurons aren't communicating to each other in the way that they should be.
No.
There's a network.
No.
It's not just a problem that's going to be in one area of the brain. It's a problem that's going to be in the different parts of the brain and in those networks that connect between different parts and help us function as best we can. Where else can we look for disease modification? Well, some people are looking at the question of alpha-synuclein. And I mentioned that already, that alpha-synuclein is this protein that then gets aggregated and it forms what we call Lewy bodies. And it's a hallmark on the pathology slide. So when you look at under the microscope of a brain of a person with Parkinson's disease. Some people think that by changing the alpha-synuclein and reducing it, you're actually going to be making the person's Parkinson's better. Personally, I'm not really convinced. I just don't think that the data has yet shown us that simply reducing the alpha-synuclein can have that effect on Parkinson, as opposed to just making it more efficient for the cleanup. If a person has a problem with energy metabolism, one thing we might want to do is fix the energy metabolism in that person. So that person may have oxidative stress, so they may have problems where their cells are actually being stressed. And what we can do is we can give things like antioxidants, and many of you have heard of antioxidants commonly used like NAC, and many physicians also recommend them. And what it can do is by reducing the amount of the damage that happens in cells because of oxygen, then actually it can help a person's cells work better. So personally, I don't think there's going to be one cure for Parkinson. I think everyone's story is a little bit different, is a little bit unique, not just in the way that you present, not just in that first symptom, not just on which side of the body it is, because it won't necessarily be on the right side if you're right-handed, or on the left side if you're left-handed. It will be on one side or the other, probably starting out more than the other. And usually we'll spread over to the other side, but not always. Sometimes we'll just become worse on that one side. And it used to be that in order to make the diagnosis, we just used clinical criteria, meaning you gave us a story, a history, and we asked, neurologists spend a lot of time asking you questions and re-asking them and asking them in a different way. And some of us say that we spend 80% of our time on just the history, on making sure we have the story exactly right. Make sure we have your story exactly right, not somebody else's. We also use the neurologic exam, and that's the Simon Says of examinations. Stick out your hands, tap them, stick out your tongue, don't do this, do that. All those sorts of things are the examination, and that's about 15%, of what we do. And then the other 5% is going to be tests. In Parkinson, there's a test that was developed and was started to be used several years ago now, and that is a dopamine scan. And basically, it's a nuclear medicine scan where what you're doing is you're looking for the irregular areas in the human brain where there's a lot of dopamine activity. And that's an area that happens to be called the basal ganglia. It's just a name, it's not important. And what you'll see is that a person with Parkinson, there's going to be a reduction of that dopamine in that area as compared to somebody of the same age, same health, but who doesn't have Parkinson's disease. DOPA scans or DAT scans are available in most places, aren't available everywhere in this country. Most insurances, most of the time, will cover it. Sometimes they won't. And it can really be confirmatory for a person that they have Parkinson's disease, because one of the issues of having any neurological condition is always second guessing it, saying, did I really have this condition or not? Maybe something else is going on. Maybe the doctors have it wrong. And that's why, to make yourself feel better, as well as to help your condition in general, it makes sense to have second and third opinions. Oftentimes people think neurologists and doctors are insulted by second opinions. Doctors should never be insulted by second opinions. We do it every day. When we show and we talk to another doctor, we might show them a scan and talk to them about a patient. We're asking advice of each other. That's how medicine is actually taught, is by people talking to each other. And so a patient going and seeing one doctor and then going for a second opinion to see if they think it's the same thing going on, or if maybe there's something else that's going on, is not insulting. And if you find a physician who's insulted by it, it might be time to find a different physician. It's not insulting to have somebody go and double check and triple check to make sure that the diagnosis is correct, especially when there's multiple things that are out of the ordinary. So if a person doesn't have much tremor is not really part of it. If a person is a lot younger than normal people are with Parkinson's disease. You may want to look a little bit more carefully. It definitely could still be Parkinson's disease. But you want to make sure that there's not something else that you're missing, not something else that the physicians are missing. So I want to open it up to questions that you might have, but I hope it's given you a little glimmer, a little view into how I, as a neurologist, see Parkinson's disease, what I think the possibilities are. I think one of the huge possibilities is going to be disease modification. Can we actually change the course of your disease? And so much so that I'm actually in the process of writing a scientific paper arguing against the use of the word neurodegenerative. I think the use of that type of language is not useful for the Parkinson community. And you have a community here. It's not useful because it implies that there's nothing to do. Degeneration is going to happen. There's nothing you can do. It's just going to keep on happening. But I think there is a lot that we can do. And we're going to find out more and more about what that is. And how do we do that? Well, we do that because of experiments that happen in the labs, because of that computer modeling that I discussed, and then ultimately through clinical trials. Being involved in a clinical trial is one of the most altruistic things that you can do, meaning giving of yourself. Because you don't know if the particular medication that you're taking in the trial is real medicine or fake medicine, placebo. You may not know if it's going to work or what the side effects are. That's why they're doing the research. Yet you're giving of yourself to help the greater Parkinson community. It's interesting. I said that it's the second most altruistic thing that you can do. I think the most altruistic actually is just going to your physician. When you go and you tell us a glimpse of your story, you have so much going on, more than what we get from that short amount of time. And I know in America it's getting shorter and shorter, but that short amount of time that we have with you in the office, you have you as a whole person. And so you're opening up to us about things that might be sensitive. One of the non-motor symptoms of Parkinson's disease could have to do with urination, could have to do with defecation, or even with sexual dysfunction. These are things that are not talked about in polite company, yet you're talking to a physician who you barely know about these, about your condition, about your hopes and dreams for what you want to do. And so I think that it makes sense for people to make sure that that therapeutic relationship they have with their neurologist is a strong therapeutic relationship. I think we're going to see changes that happen. I think in the next 5-10 years, we're going to see many more discoveries in Parkinson. We're going to understand it better. We're going to understand more about why one person gets Parkinson, one person gets Alzheimer, and one person doesn't get either of them. I think these are things that we're getting closer and closer to actually discovering. And once we do understand more and more, then we'll be able to not just simply describe Parkinson's disease like James Parkinson did in 1817. We'll actually be able to do something to change the course of the disease. I would love to open up to any questions that you might have. The question was, if someone has been told that they have a tremor-dominant Parkinson's disease, but yet the progression has been very slow over the past 4 years, is that atypical? And does that mean that it's going to stay that way, or is it going to change? And unfortunately, people's progression with Parkinson's disease is actually very variable. Some people are going to have a faster deterioration, a faster involvement of different aspects of their movement and non-movement. And other people are going to have it much slower. Some people are going to have tremor be a big part of what they're having. And other people, it's going to be more about slowness of movement, or something called masked faces, where you can't really see the person expressing as many emotions. They may be as happy or as sad as somebody else, but they just look like they're not expressing as many emotions. And so just by the time course alone, it's difficult to say that something is less likely Parkinson. Now, there are a couple of things about tremor dominant that need to be said. One is to make sure that it's really tremor dominant Parkinson and not something like essential tremor. essential tremor or benign familial tremor. It's not so benign always, and it's not always that familial, but it basically is a tremor that's not going to cause or turn into Parkinson's disease. And a lot of times you'll see that in families. And a lot of times Uncle Joe, maybe he had tremors, but every time he drank a beer, he no longer had that tremor. That's a sort of typical story for essential tremor. And the implications of essential tremor are very different than the implications of Parkinson's disease. One of the things that we look at is looking at that dopamine scan. We might also look at alpha-synuclein, that same protein I talked about. It's been found that alpha-synuclein is higher in people with Parkinson's disease, even not in their brain, so in other areas. So there's a skin biopsy that can be done that can show a higher amounts of alpha-synuclein in a person with Parkinson's disease than a person without Parkinson's disease. There's research looking at spinal fluid. It's not mainstream now to look at your spinal fluid. Don't worry, you don't have to go and get a lumbar puncture. And to see if alpha-synuclein can be involved there. We're trying to understand more about what puts that person at risk for that in general. One of the things might be your gut bacteria that you have, called the microbiome. And your microbiome may be different in a person with Parkinson's disease than a person without it. And the question is, can you change that microbiome? So we have bacteria all over us, on our skin, but in our stomach and in our intestines, we have a lot of bacteria. And then bacteria is overall usually considered good bacteria because it breaks down the food and breaks down the medications. But sometimes a person may have alterations or changes from what should be in their area of the country, what should be their microbiome, what kind of bacteria. And we think that may have an effect on not necessarily giving someone Parkinson, but taking Parkinson and maybe making a person have more what we call motor fluctuations, more changes throughout the day. And you probably heard doctors refer to this idea of on or off. It's a strange term, and it's really unique to the world of Parkinson's disease. We don't, in other conditions, we don't talk about strokes being on and off. We don't talk about Alzheimer's being on and off. We don't talk about multiple sclerosis being on and off. What we really mean by on and off is just a description of when you have high levels of the medicine in your bloodstream and you're doing better from the movement point of view. That's when you're on. When you're off, oftentimes will be when the medicine goes down, when it dips down. And that's why there's certain things we do to try to keep a more sustained level. And then, especially if someone has tremor dominant, sometimes we think about something called deep brain stimulation, or DBS. And DBS is basically they drill a hole in the person's head, in their skull, and they put an electrode into the area that's involved with movement with Parkinson. And by giving electrical stimulation, they're able to actually overcome all the signals and actually overcome it so much that it calms down the tremor. By stimulating, it actually overcomes the tremor. And a person with Parkinson's disease who's had deep brain stimulation, oftentimes the tremor especially will be one of the symptoms that can be affected and be one of the symptoms that can actually get better. So we definitely talk about dominance in terms of whether someone's more tremor dominant, whether someone's more bradykinesia dominant, more dominant on slowness of movement versus tremor. Oftentimes, just having much more tremor than anything else can actually, I know it doesn't make sense, but can actually, because it feels like it's more noticeable, but oftentimes it can be a slower progression of the Parkinson's disease. But again, we don't yet have what we call biomarkers to tell us what person is going to, A, get Parkinson's disease, and B, if the Parkinson's disease is going to be really affecting them a lot, or if it's going to be a slower progression. We don't yet have those ways. We're trying to develop them. There's a lot of research going into this, but for as much as we've done in modern medicine, there are some basic questions in neurology that we still haven't answered. The question was about B1. B1, so vitamin B1, also called thiamine, There's been some interest of this in Parkinson's disease. What's been noticed is that if you, in some trials, and these aren't large trials, and they're not greatly designed trials. What I mean by that is the best type of clinical trial is when you take people with a condition and you give half the group one treatment and half the group, let's say, no treatment, placebo. And you see what the difference is in how people end up. And even if you compare it to yourself, even if you do what's called a crossover design, where the person gets one treatment and then washes out and then gets another treatment. The studies that have been done with thiamine have been with injectable thiamine, so injectable vitamin B1. And B1 is found in lots of types of food, as well as fortification in cereals and other things as well. And what's been found is that there was some reduction in the Parkinson's symptoms. Part of the problem is those trials didn't have a placebo arm, so we don't know how much of it was a true effect and how much of it was just an effect because being part of a clinical trial, especially when you have Parkinson's disease, can give you what you call a placebo effect, can make you feel like you're getting better, even though nothing actually has changed. Dopamine is an important neurotransmitter in the body, not just for movement, it's also for our reward center. So when you think about people who overly gamble or other kinds of things, they have too much dopamine going on in certain parts of the brain. And so a person with Parkinson's disease, because there's alterations in the dopamine, there may be more placebo effect than we see in people with other types of conditions. And actually, the Food and Drug Administration, or the FDA, recognizes that specifically in Parkinson's disease, that controlling against a placebo or against a standard therapy is much more important than even in other conditions as well. So what does that mean you should do now? Well, vitamin B1 is available in lots of foods. It's available as a supplement. It's a B vitamin, which means that it's water soluble, which means you pee it out. It doesn't get deposited in your fat like A, D, E, and K. And so you're not going to get too much of it, hopefully. It's very hard to overdose on it. Everything you can overdose on, but it's very hard to with vitamin B1. And so taking it as part of your whole healthy life. So eating the right things, exercising, you brought up physical therapy, giving physical therapy, trying to do different kinds of movements. Specifically in Parkinson, there's even good data on using boxing as kind of not hitting other people, but using boxing movements to kind of help the person with Parkinson and help them function better. So part of the whole healthy lifestyle, adding B1, I don't think is a bad idea at all. I do think you're having a very good response to vitamin B1. And I think it makes a lot of sense for you to come back to your neurologist, even if they haven't made an appointment for, they say next time you see them is far ways away, maybe make an earlier appointment and specifically bring up the issue of B1 that you think is helping. And this is what it's helping. Because, for example, you just described that your smile, that you're able to have more facial gestures. That makes sense that that's improving. It makes sense that is one of the problems in Parkinson is because of the slowness of movement and because of the reduction of movement. Then what will happen is the person will have what I call a masked faces. And so they won't be smiling as much. But then the B1 is making you do it more. That's something that can actually, that's a real benefit to you. And your doctor may want to think about not just supplementing orally. They may want to think about supplementing also injectable vitamin B1. Exercise definitely helps symptomatically. So it can help different symptoms. It can definitely make you feel better. Exercise is important for many, many reasons. There does seem to be something in general in neurological conditions where exercise can actually be not just beneficial for your symptoms, it can actually maybe disease modify. I don't think exercise alone could be a full-on disease-modifying treatment for Parkinson's disease, but people who exercise, they do have better outcomes. So there is something better about it. And oftentimes you'll see studies. One study might be one type of exercise, another one might be another type of aerobic exercise. It's not so important exactly which type it is, But aerobic exercise, really trying to stress the body in your exercise, actually looks like it's very beneficial, not just to Parkinson's disease, but to other conditions, and it really can help not just with physical function, but with cognitive or thinking as well. The question was, I brought up the issue of perhaps there's an autoimmune component to Parkinson's disease, so does it make sense to go to a rheumatologist? It's Parkinson's disease is not in mainstream considered an autoimmune disorder. There are aspects of it that sound autoimmune, right? Specific types of cells are attacked and are reduced. So maybe the body is attacking itself. But a rheumatologist will look for rheumatologic conditions, and oftentimes some of those are other autoimmune disorders, but not specifically with Parkinson's disease. So I don't think that most rheumatologists would feel comfortable being part of that Parkinson's disease treatment. Now, if you also have rheumatoid arthritis or also have lupus or something else, then that's the different story. But just for the Parkinson, I don't think that most rheumatologists would necessarily have much to add. You're asking if there's other types of proteins that are clumped together besides alpha-synuclein. Yeah. So yes. The question was if in Parkinson's disease we talk about alpha-synuclein and these aggregates, and we call them Lewy bodies. Are there other types of proteins? It's really more specifically what we call the alpha-synuclein aggregates. When you have a person who has Alzheimer's disease, not Parkinson, then you're going to have amyloid. But with both of them, you may see some crossover. So a person who has Alzheimer's may also have some more of the alpha-synuclein deposits. So telling you that they're not good in general at garbage disposal. But when it becomes much more of one type of disposal than the other, then that's when we think it's really connected. So although tau and other types of proteins may be involved in Parkinson, by far alpha-synuclein is the one that we're looking at. Great question about sleep, and it's a little bit like a question of chicken and egg, which came first. Although a person with Parkinson's disease, when you ask them about their REM sleep, and you'll find that there was problems for 20 years before the diagnosis, we don't think that a sleep problem leads to Parkinson's disease. It's probably another aspect that's causing both the Parkinson and the sleeping problems. It's probably not being caused by the sleep problems. With that said, it was only 5-10 years ago that we discovered that the human brain has a lymphatic system. You know, we have a lymphatic system throughout our body, and we always thought that the human brain just doesn't have lymph nodes and doesn't have a lymph system. It was only 5-10 years ago that we discovered a whole new other aspect of the human brain. It's kind of amazing when you think about it. You think everything's been discovered, but then you discover something new. And sleep probably is a time when our body rids itself of different kinds of toxins, rids itself of the wear and tear that happens throughout the day, rids itself of other things you've been exposed to, and by doing that is able to help you restore. And when you have non-restorative sleep, that can make everything worse. So although I don't think that the sleep disorder is going to cause Parkinson, I think having a sleep disorder can make your Parkinson's symptoms worse, and it can make it more troublesome. And oftentimes what people need to do is figure out why they're having that sleep problem. Is it a problem of falling asleep? Is it a problem of staying asleep? Is it a problem of you sleeping the right amount of hours, but it's just non-restorative? Is it that your bed partner is snoring too loudly and you're not able to sleep? The most common sleep disorder in the United States is not any of these other fancy kind of conditions that you see on TV or anything. The most common is actually poor sleep hygiene. And what I mean by that is the bedroom is supposed to be used for two things, and one of them is sleep, and the other one is not watching television. We use our bedrooms, especially in America, we use our bedrooms for too much. Sometimes people eat in their beds, sometimes people watch TV in their beds. There's all these other things we do that make it a non-restful place. And there can already be other things going on in your life. And then not having the bedroom be a sleepy place can all compound it. But there also are, obstructive sleep apnea and other kinds of actual sleep disorders that aren't caused by the Parkinson disease, but you can see it in people with Parkinson. So if somebody especially has a neck problem where they're not breathing as well at nighttime and their throat is collapsing, well, that means you're going to wake up for little micro awakenings. You probably don't even notice it, but your bed partner might hear you gasping for air. If you're not getting enough oxygen throughout the night, then you're not sleeping well, and then all of your neurological functions will be bad. And so a big aspect of that sometimes is to actually go and get a sleep study called a polysomnogram. There's also something called MSLT, so multi-sleep latency test. And what we're doing there is we're trying to do, these are the napping tests to see if someone falls asleep too easily, as opposed to somebody who's falling asleep and being hard. Somebody who falls asleep and directly goes into REM sleep. Sometimes that can happen too. And you can see that in things like narcolepsy. So a sleep disorder specialist who oftentimes are either neurologists or pulmonologists, so lung doctors, both of those, or ENTs, also ear, nose, and throat doctors. All three of those fields go into something called sleep medicine. So it may be someone different than your regular neurologist who's taking care of your Parkinson's disease, but it may just clear up to make sure there is some other problem causing the sleep problem. It goes without saying that having a more supportive system is better than having a less supportive system. The question is whether there's hard science that really demonstrates it. It's difficult to design a trial where you have really hard ways of doing it, because one way you could do is you could say, well, I have one group of people who have supportive systems and another group that don't. The problem is everyone's support system is different. And also what you consider non-supportive, somebody else might consider overly supportive. So it doesn't hurt anyone to be in a supportive environment. And so it's not like there's a risk of having a supportive environment. The more supportive the environment can be, the more your not only Parkinson can be better, but the more other things like diabetes, like heart disease, like high blood pressure, the more those can be better as well. Because remember, when you have Parkinson, it doesn't protect you against having all these other sorts of problems that we get as we age. And so having a more supportive system could make a lot more sense. And that support can come in lots of different ways. So it can come from family, it can come from friends, come from religious places of worship. It can come from specific Parkinson's support groups where you share your journey with other people with Parkinson's disease. Those are available both in person in a lot of places, but also online. There's virtual support systems. Here with WeHealth, WeHealth has tried to have a support system where you really have an interaction, and I would say a support system based on knowledge, based on the more you know, the better. Sort of like those commercials, the more you know, ... And the idea is that if we can be there for each other, then we can help each other get into a better condition. The question is, how do you know that you have Parkinson versus what we sometimes call Parkinson plus? Parkinson plus are conditions that are similar to Parkinson's disease, but aren't actually Parkinson's disease. And so one of them is called PSP, or progressive supranuclear palsy. A person especially has problems with moving their eyes up and down. And one of the ways that we tell the difference is based on the history, based on the exam. We do use things like that DAT scan, so that the idea of that dopamine scan to see. And we do things like these alpha-synuclein testing in the skin biopsy to tell us if it's more likely or not that one condition is there versus the other. And then the other way is also making sure that you're not just having that one opinion of that person who makes you walk and turn around, but that you also see another person, another perhaps movement disorder specialist or perhaps other kind of special, other kinds of neurologists in order to make sure that you get diagnosed correctly. There is always a tendency to believe that you or your loved one do not have the disease that we're talking about. It's a natural aspect. It's a natural thing of being diagnosed. Is, well, how could it be? I don't have anyone in my family. Well, most people don't have somebody in their family. What did I do? I didn't work in agriculture. Why is this happening to me? What is going on? We don't fully understand why some people get Parkinson's and other people don't. We don't understand why in some places there's more Parkinson's and some places less Parkinson's. But when they asked Michael J. Fox, so America's sweetheart, they asked him, he was part of a television show before Family Ties. There was a sitcom in Canada, and many people in that sitcom all got diagnosed with Parkinson's disease. So it looked like there was a cluster, what we call a cluster, where a group of people in a similar area who developed the same disease. And the question is why? Was there something that they were exposed to? Was there something else? Why was it just by chance? Why did this happen? When they asked him why he doesn't use the resources of the Michael J. Fox Foundation to study that, he answered, the gentleman that he is that there's a lot of other types of clusters in the world, and much bigger and more important than the one that he happened to be part of. So you can't know for sure that you have Parkinson's disease until you've really gone and seen, I would say, probably 1 or 2 second opinions to make sure that this isn't something else. And I think it's actually a very, very good question to ask, to say, my specific question is this Parkinson's disease, or is this something else? Is this Parkinson plus, something like PSP? The answer to that is going to be very different for different people because people's jobs are different. Not only is their Parkinson different, their jobs and the strenuousness of that job. So, for example, if you're a concert pianist and you're having tremor, well, you're probably going to have to stop working a lot earlier than somebody who doesn't have tremor and is somebody who sits in the office as like an attorney or an accountant. So it's going to depend on what type of work you do, and also it's going to depend on how that Parkinson's, how it's affected you. The great thing about living in the United States is the American with Disabilities Act, the ADA. So what that means is your employer is supposed to give reasonable accommodations, but they can't give reasonable accommodations unless you disclose to them that you have the diagnosis. So for oftentimes people might want to be private, especially at the beginning, about their diagnosis. They may not want to share it with colleagues and coworkers, and it might not be the right time to disclose it to your employer. But then at a certain point, it can be that it makes sense for you at that moment in time to disclose it because there's some easy, reasonable accommodations that can be made. For example, bigger pens so that your pen isn't so thin and so it's so hard to hold when you have tremor. Doing different kinds of accommodations to make it easier for you to get in and out of a restroom or something else, with things that the employer can definitely do. They should not be reasons why your job is challenged. You should see an attorney if that happens. And it can let people stay productive, what we call productive members of society, staying in their job for as long as possible. So the question was about coenzyme Q10. So this is another, I would say, supplement that we offer a lot of people with Parkinson's disease. And the data is a little bit mixed, where it looks like in some trials, and these aren't very large trials necessarily, but in some trials it looks like by adding coenzyme Q10 to a person with Parkinson to their whole regimen, you're making their Parkinson a little bit better. And so what that means is a lot of physicians have almost like a cocktail. If you're willing to take other if you're willing to take more medicines. That also depends on if you're on a lot of medicines for something else, right? So if you have other conditions, you may be already on so many pills, it's just too much to ask. But if not, there may be like a cocktail of pills that make sense to have, like have some coenzyme Q10, perhaps have NAC or either NAC or glutathione, have some B1, so thiamine, all these kinds of things that probably aren't going to hurt you, may help you, may not, may help you, and have reasons to think that that it actually helps the functioning of those cells get better. What I hope we get to is a point where we're able to test your blood itself and say, oh, you're a person who coenzyme Q10 is going to help. And you're a person who coenzyme Q10, it's nice to take, but it's not really going to do anything for the Parkinson's. And that will have to do more when we understand why one person develops Parkinson and another person doesn't. One of the reasons why in a lot of places where they do a lot of deep brain stimulation surgeries, they may have people either fill out paperwork or people actually go and usually see an actual psychologist, is because they want to make sure that before they do a surgery that this person's going to really be part of it. This is brain surgery. It's not complicated surgery, but it still is surgery where you're actually going into a person's brain. And so you want to make sure that the person's going to be adherent to what's going on, that the person's going to manage their deep brain stimulation well. If you, in all other ways, make sense for deep brain stimulation, but you have a history of depression, not suicidal depression, but like you have a history of depression and you're being treated, I would talk again to the place. I would perhaps consider going to a different deep brain stimulation center where they've done a lot of these surgeries, because it's not a clear contraindication for deep brain stimulation.
Excellent. Well, thank you all for joining. Thank you so much, Dr. Kantor. I think this was incredibly informative. I mean, you can just tell from the chat, everyone is, very, very appreciative of your time. And I think this was just a fantastic session. Please be on the lookout for a follow-up. We'll be sending out a feedback survey, as well as we'll be packaging up this webinar and resharing it with you so that you can go back and reference anything and take notes. And again, thank you all for your participation.
And if you want to stay connected, at Gateway, we actually just started a forum so people can actually stay connected and hear more about updates as they happen. And it's a fairly easy website. It's gifbr.com. So Gateway Institute for Brain Research.com. So gifbr.com. And there's a section on the right where you say stay connected, and you'll hear about studies as they're coming out and results as they're coming out as well.
Excellent. And we'll include that link as well in our follow-up with everyone. But otherwise, thank you all so much for your participation. And again, thank you so much, Dr. Kantor, for this invaluable session. I think not only for the folks that were here, but I think for the thousands of patients that are a part of our community, I think they're going to find tremendous value from this. So thank you again.